ready. I'd like to introduce Dr. Jeff Cordes to you. Dr. Cordes is a psychiatrist. He also came through our geriatric fellowship program, so he is truly a psychiatrist with really good geriatrics background. And of course now he not only, it says here, runs the geriatric psychiatry program in the residency program, but he really works with our fellows as well in extreme amounts of time to help them get a really good grasp on what's happening with their older patients psychologically. And is going to do the same thing, I'm hoping, with you right now.
All right.
And we have to plug you in. Great.
Okay. Can you hear me okay?
Can you hear him?
Yeah.
Okay, good.
Yeah? Can't hear myself hardly. Okay, thank you, Michelle. You can really all hear me?
Yeah.
That's astonishing. Okay. Very well. Yeah, I've been asked to speak with you about how a geriatric psychiatrist approaches the evaluation of an elderly patient. Before I get started, I'd like to get a sense of who all is in my audience. So what are all of you? Dental hygienist, nursing,
A social worker too.
social worker too. Psychology. Good. Okay, great. So a little bit of diversity is great. Very fine. So what I'd like to cover today is a few basic points. So what I'm going to start with is I don't have any financial relationships to disclose today, so let me cover the basic objectives that we're going to be talking about today. The first thing is I'd like for you to come away with today's talk being able to define what dementia is, and I've given you some handouts, so most of this is in there, and I hopefully left enough space for you to take additional notes. I'd like for you to know what dementia is, and then what features of dementia are most associated with functional impairment. And then we're going to spend most of our time on the actual clinical assessment of cognition, and I'm going to focus on actually how we go about testing an important part of cognition called executive function. We'll have some video in the middle of this, and it's okay if you record or videotape this presentation, except for the part where the video is, so I'd appreciate if nobody videotaped or recorded that section of this presentation. All right, so let's start by talking. If I walk over here, I assume you can still hear me. Is that correct? Great. Okay. So I'd like to start by talking about the general diagnostic criteria for dementia. And what most people know about dementia is that it's a disorder that affects memory, right? When you talk to a layperson even, they know that dementia is a disorder that affects memory. And according to our DSM manual, which is the Diagnostic and Statistical Manual of Psychiatry, that covers the syndromes that we see in clinical practice. It also includes one or more of the following features: aphasia, apraxia, agnosia, or disturbance in executive functioning. Aphasia is a language problem. Apraxia is a problem carrying out instructions or complicated commands. And agnosia is problems with recognition. This can be recognition of objects or people or things like that. And then finally, disturbance of executive functioning. It also has to be a decline from previous level of functioning. So someone who maybe has mental retardation or autistic disorder or something like that, that's a lifelong condition, wouldn't be defined as demented according to these criteria. Okay. So, as a geriatric psychiatrist, the main thing that I'm keying in on when I'm seeing a patient is whether or not their cognition is intact or not. And if it's not, I'm mostly worried about whether or not they have executive impairment. Now, executive impairment may not be a term that all of you are completely familiar with, but I'm sure most of you have heard it in some capacity. Is that correct? Maybe? All right. Anyway, let's go over a little bit about the definition of terms. It's otherwise known as executive control function or executive cognitive function, or sometimes just abbreviated as ECF. And there's basically two general themes that cover this construct or concept. One of those themes is that executive function involves higher cognitive processes. And this is one of the ones that you'll see the most referred to maybe in grand rounds presentations or things like that, that executive function has to do with insight or will or abstracting abilities and judgment and things like that. So, if you ask a person, how are a poem and a statue alike, that draws on a person's ability to abstract that maybe they're both meaningful, symbolic, works of art, something like that, as an example of executive functioning. And it sounds, when you describe it that way, it doesn't sound like it has all that much of an impact in a practical way in the real world on a day-to-day basis. On the other hand, there's another way of looking at executive functioning that has to do with the fact that it's a control function, that there's a piloting sort of task that the brain carries out that oversees and monitors and manages lower cognitive functions and helps organize behaviors, thoughts, and actions. Okay, and it's mostly in that area that I think executive function impacts our geriatric patients in a very meaningful and practical manner. All right. Executive function, the term, is sort of a creature that was born in the early 1990s. If you look at this slide, you'll see that prior to 1990, there was very few citations in the literature, and over time, each year, there's more and more and more literature describing this concept and its impact on functioning. So, interesting to see what 2005 is like compared to the past years, but it should be an exponentially increasing amount. Okay, so executive functioning has to do with the cognitive skills that are involved with organizing complex goal-directed behavior. Okay, so in order to carry out an activity, you have to make a plan, you have to identify a goal and a target and what you basically want to do, and then you have to get started. Right? You have to initiate the behavior, and then you have to do most behaviors in the proper sequence, that there's steps involved and you have to do them one at a time, and if you get it all jumbled up or mixed up, you don't have the right outcome, right? And then you have to monitor yourself along the way, so to make sure that things are going according to your plan, or that you're modifying things if your plan needs to change somewhere midstream perhaps. All right. I'm not going to go over a lot of detail in this slide because you have it in your handout, but basically executive functioning errors are often seen as described here. Someone has difficulty shifting gears, as in changing from one set to another, problems with verbal fluency, word finding problems, and perseverating on one task when they should be moving on to another task, and other things like repeating behaviors or utilizing things in the environment that are there simply as a cue rather than as something that's necessary to accomplish a goal. And we'll talk about some of these things again in a little bit. All right, so why is executive functioning important? Well, one of the main reasons is that it's extremely common. Second reason is that it's associated with actual functional disability. And third, and this is important, is that most standard screening instruments are insensitive to detecting executive function impairment. Okay, so are all of you familiar with the mini mental state examination? Yeah, how many items are on that thing? What's the top score you can get? 30, yeah, that's right. Just checking to see if y'all really knew what it was. All right, so it's 30 points, and it has to do with assessing a person's memory, language, constructional abilities, and a little bit of concentration type tests on there, praxis types items. But actually, it's relatively blind to executive function impairments. So if you screen someone with the mini mental and they test out okay within normal limits, then you might be overlooking patients that actually have executive impairment. All right. So as I showed you on a previous slide, the DSM-4 defines dementia as including executive function impairments. And in my opinion, it actually is probably the essential feature that makes someone demented or not. So, and that's why it's found in most of the conditions that we consider to be dementias, like Alzheimer's disease, vascular dementia, and another relatively common condition known as frontotemporal dementia, and others as well. All right. Now, executive function impairment cuts across all kinds of diagnoses, and pretty much any psychiatric condition you can think of is associated with executive function impairment. And this includes schizophrenia, major depression when it's really bad, bipolar disorder, particularly when someone is in an acute episode, And of course, probably most of you are not surprised that someone who is intoxicated with any illicit substance or alcohol is also executively impaired, and that's why people do stupid things, right, when they're intoxicated. And you ever work in an emergency room, or maybe as an EMS worker or a police officer where you have to interface with intoxicated patients, right? They're saying things that they shouldn't be saying, right? They're doing things that maybe they ought to not do, and those are all examples of executive type errors. And those can all completely resolve when the intoxication is over, right? And these problems can also occur in the context of substance withdrawal. And in some cases, the damage is sort of done, if you will, and persists. So some people with alcohol-induced persisting dementia, even though they may stop drinking, they remain demented indefinitely. And certain personality disorders also have problems with executive function impairment. All right, so it would be one thing if the story stopped there, but actually these impairments are found in non-psychiatric conditions. Okay, these include vascular disease and the things that are associated with vascular disease that you see there, and a whole host of other medical problems, HIV-associated dementia, end-stage renal disease, and certain malignancies, all are associated with executive function impairment. And particularly that top line, that includes virtually all the patients that I see at the VA. Almost all of them have at least one of those conditions. All right, to give you some sense of how prevalent this problem is, we'll look at a little bit of data that was gathered here at our institution by one of our fellows, our current graduating fellow actually, who looked at patients seen by the psychiatry service on the consultation service. And the psychiatric consultation service sees patients that are like on the medicine service or the surgery service at either the VA or University Hospital next door. And they found that 72% of the patients they evaluated routinely had executive impairment. And this compares to only 30% of them being identified by using the mini-mental mental state examination. So you can see there's a big difference between who you would identify and who you wouldn't identify depending on which tools you use to measure them. All right, a similar project was done by one of your speakers you'll be having later this week, Dr. Monica Horton and Dr. Schillerstrom together looked at patients who were on a general medical ward. These are not patients referred to psychiatry, just your average patients that were seen over I believe it was a 1 month period, and they found that 52% of them were executively impaired, but if you looked at them only with the mini-mental, you'd find only 9% impaired. So a huge percentage of the patients are actually impaired, and you might not even know it if you're not looking for it in the proper manner. Okay, so briefly, let me just talk about what some of the impacts of executive impairment are. And it's associated with the level of care that a person needs. For example, in retirement communities, those with the most executive impairment need the greatest amount of care. Level of supervision after traumatic brain injury, medication compliance, IADLs and ADLs. Y'all know what the difference is, mostly? Instrumental activities of daily living and activities of daily living. Some sense of what that is? Not sure exactly where you're at on this, but okay, I'll assume that you know what that is. How well a person can participate in a rehab program is associated with how executively impaired or not they are. And finally, sort of in forensic situations, how well they can understand the medical information that's being presented to them in terms of to what degree they can understand what their basic medical problem is, what the proposed and available treatments are, what the alternatives are, what the basic risks and benefits of each of the proposed treatments are, and how well they can make a decision is all associated with executive functioning as well. So it covers a lot of ground. All right, so how do you go about detecting or measuring executive impairment? There actually isn't an established gold standard at this point. So I'll just briefly talk to you a little bit about what sorts of things are available. The formal measures, and these are mostly the kinds of instruments that highly trained psychologists use, and one of the ones that you see the most in the literature is called the Wisconsin Card Sort. And I'll just kind of run through some of these. The Stroop Color Word test, the Dementia Rating Scale, and then there's tests involving tinker toys. You remember your tinker toys when you were a kid growing up. There's tests that involve putting together different sorts of objects using those child's toys. The Tower of Hanoi, Tower of London, and others require the person to work out a strategy to make the tower stack in the least number of moves. Then there's some maze tests and other kinds of tests that are available, and these are all fine, but they do require some special training, and you also have to have special equipment in order to carry these out. So these are not as practical as other measures, but I did want you to be aware of them so you know that they're out there. Then there's another broad category of measures that are considered bedside measures, and you can see them listed in your handout as well. The behavioral discontrol scale, design fluency tasks, FAB, go, no-go tasks, things like this, trail making tests. Maybe you've seen the trail making test, is probably the most well-known of those, and others there. What we use at our institution here is the executive interview and the clocks, and an executive clock drawing task. And those are two instruments that were developed here at our Health Science Center that I'll talk to you about in some more detail, I guess, at this point. So the executive interview was developed by Dr. Donald Royal in our department and was published in 1992 and has been published and cited a number of times in the medical literature. And this is one of the main instruments that we use for training and clinical purposes here at our institution. But let me emphasize that a lot of other places don't use it. So now that you're kind of seeing the light here and you're informed, if you go to some other meeting in some other place, they may not know what you're talking about. Even though you're kind of ahead of the curve and on the cutting edge of things, they may not be as familiar with what you're talking about. And the executive interview basically provides a standardized way to approach a patient in a clinical encounter that allows you to demonstrate that they have executive discontrol. And it can be done at the bedside. And it's essentially a compendium of different kinds of tests, and you see them listed there. And I'm going to show you some actual video of the test being conducted so you have a much better idea of what I'm talking about. Okay? All right. So basically there's 25 items on this test. And it takes about 20 minutes to administer, which in some settings is way too long, right? 20 minutes doing one task to get one piece of information is just too long in certain settings. As a geriatric psychiatrist, it's critically important, so I make the time. But if you're a nurse or a social worker or in some other discipline, then it may not be practical for you to do. But I do want you to see it because it kind of highlights about what we're talking about that an executive impairment actually looks like. Because I can talk about this all day, but you may not have a good grasp of what I'm talking about until you see it with your own eyes. Okay, so the exit is, or the exit 25, or the executive interview, I'll probably call it the exit today so you know what I'm talking about, correlates well with some of those other measures that we were talking about in one of the previous slides. Okay, so let me stop there and reduce this window. I heard some of you sort of commenting out loud about how it was making you feel while the demented patient was going through this, right? What did you want to do while he was help him, right? Like he kind of elicits that. He wants you to stand in, right? He in the real world, that you'll probably jump in there. Well, no, it could be worse to start with the letter A. Like it might be names, or like Adam, or right. You want to go in there and try to help him out and give him some pointers, or give him some assistance, or guide him, or redirect him, or throughout that there's a sort of a tendency from probably most of us to want to do that, right? And so that's an important point. And the fact that we're all kind of wanting to jump in there and help him and guide him through these tasks, that should be a big clue when you're dealing with real world patients. If you're needing to do that, if you're feeling the urge to jump in and help someone with something that a 30-year-old patient ought to do without any assistance whatsoever, then that's probably an executive problem, okay? Because what we're wanting to do is we're wanting to stand in there and be his frontal lobe, if you will. We're wanting to be his mommy. We're wanting to be his executive function, okay? To stand in there and actually guide him through things that other patients wouldn't need the guidance for. Okay, so that's a really good point to bring out in watching that video, because in the real world you'll see this all the time, even though you're not tested for it. Okay, maybe the food tray that the person is having difficulty navigating in a nursing home setting, or with some sort of rehab maneuver. You'll have the urge to step in and try to help a patient out. And the fact that you're having to do that, you need to step back and think to yourself, does the average 25-year-old need me to do this? And if not, why is it that this patient does? And chances are it will be sort of an executive deficit that you're noticing. What other things did you notice from the videos?
He never removed his hand from the top of his head.
Yeah, right. And did y'all notice that? So when the first example, she said, put your left hand on top of your head and close your eyes. He went like this, and then she said that was good, and then he moved on to the next task, right? The demented patient went like this and then maintained that posture sort of indefinitely, right? So the doctor never asked the patient to take his hand down or open his eyes, but the first patient knew to do that automatically because it was implied. The body language, the context told him what to do next, okay? Patients with executive functioning, the context doesn't always tell them what to do, or it doesn't tell them the best choice. So until he's told to take his hand down and open his eyes, sometimes he'll keep his position like this. All right. What other things did you notice? What's that? This one? Yeah, so okay, so let's talk about this. So squeeze my fingers. The normal response is to squeeze your fingers, right? Okay, what did he do? Yeah, he like maybe grabbed them and pulled them together. Why would he do that? Any ideas? Yeah, right, they're pointing together, right? They're like arrows. You know, so he brings the arrows together. Ooh. All right. Now, probably most of you wouldn't think to do that, right? Right? But they do this. And other things that you'll get sometimes is they'll imitate exactly what you did. You say, squeeze my fingers, and they go, whoop. Exactly what you did. All right, so those are good examples. What else did you notice?
She explained
Yeah.
continuously.
Right.
That's like the thing he went back to the most.
Yeah. Yeah.
repeatedly.
Right, so even though he probably has Alzheimer's disease and probably has a terrible memory, he was able to, you know, some things get in and stay there and rattle it around and come out at the wrong time later on, right? Even though he couldn't remember the three objects after, you know, just a brief amount of time, he was able to hold on to the idea that something was important about the alphabet and numbers, right? So he was able to continue that even into the next task, which was inappropriate, right? Yeah. Good. What else?
More an observation as far as the good example of this take was, because as dental hygienists, we are educators, and so
Yes.
we teach our patients, and we many times have patients in our chair that are at early dementia.
Yes.
Having to, will encounter some of these things when we're trying to teach them.
Right. So, okay, that's a good point. So, one of the things that I noticed when we were watching the video right now was that the demented patient kept kind of jumping in too soon. You know, she had to keep telling him, now wait, well, you watch, you know, watch while I do this, or whatever it was she was doing in the task, you know. She said, can you do this? And as soon as she started, he says, yes, I can do that. But, you know, in order to know what she's teaching him, he has to pause and watch and observe all the important information before he jumps in. But he jumps in right away before he even knows what to do. And same thing with some of the other tasks. You know, what would come next? Before she even says that, he says C. You know, 1A, 2B, 3C. He says C before she even tells him what the task is or what they're doing. Okay? So as a dental hygienist, you might be trying to instruct a patient how to do proper oral care. And if he or she is jumping in before you're finished with what you're saying, and you'll probably see this actually, that might be a clue that there's something wrong here. Okay? What else? So a lot of things, we'll probably miss some of them.
Well, on this song, I noticed, when I was watching, I was like, oh, okay. I caught some words that were different, like are on the Pledge of Allegiance.
Oh, yeah.
Those flags. And I caught that where someone that has dementia would refer back to what they used to think, like what they did.
Yeah. Yeah, that's right. Yeah, so the exit, which we were watching pieces of, is designed to elicit these kinds of things. So each of the examiner gave the patient phrases to repeat back, right? So I pledge allegiance to those flags. which sounds a lot like I pledge allegiance to the flag, but is different, right? And each one of those things, a tinkle, tinkle, little star, for example, those are similar to what we've all learned living in the United States, growing up or whatever, but are different enough that it requires you to be a little bit vigilant when you repeat it, because there's a little flaw, there's an error, there's something different compared to the way you've learned it, right? So the task is to say something that you have habits for saying a different way. Saying it in the way that's required right now, not the old way that you did when you were in second grade. Okay, so in his case, he not only didn't say it exactly the way she did, he went way past it, right? He didn't just say, I pledge allegiance to the flag. He said, I pledge allegiance to the flag of the United States of America, right? Okay, so sometimes you'll see that with any of those phrases. Let's see. You might not have been able to see very well, she showed a picture. And basically there's a tree limb with a bird and a cat behind it and a little girl dressed in warm weather clothing and snow on the ground with her arms outstretched to the cat. And the patient is asked to tell me what's happening in this picture, right? And the first example did a very efficient description, right? Well, it looks like the cat's trying to get the bird, and it's cold outside, it's winter, she's wearing gloves, it's snowing, whatever. But the other patient had a great difficulty telling a story about it, right?
I think even to the point where today was, when he didn't even like see the tree.
Yeah, he said there's twigs, right? Right, and sometimes they'll say, well, it looks like there's some twigs growing out of the back of the cat. You know, they can't even see that that's just in the background behind the cat. So they just don't see the world, they don't see the big picture. In order to function well independently, you have to be able to see the big picture to know what to do next. Okay? Because in the big picture, there's all kinds of stimuli, all kinds of possible behaviors that you can undertake, and you have to decide what is the best behavior to reach a certain goal. Sometimes the best behavior is to sit quietly even though your bladder is getting full and you want to go to the bathroom. Right? Or sometimes the best behavior is to pretend that you're interested and awake even though the person you're speaking to is very boring or whatever, right? I mean, you have to decide what the best behavior is. Anyway, so by showing examples of what executive failures are like, I think it gives you a better idea of what I'm talking about. Okay, this is very practical. You see this in the real world. Anyone who actually has hands-on contact with real-world patients sees this all the time if you're in geriatrics. Okay. So in my opinion, one of the things that distinguishes geriatric medicine from just regular medicine is the cognitive part, the psychiatry part, if you will, the executive part. There's one thing that distinguishes older patients from younger patients is that they're more likely to be executively impaired. And if they are, then you have to take that into account and change the way you approach them. You may have to give the instructions to the caregiver rather than to the patient. Right?
Do you think that some patients or people get a little further along than maybe they should? Because, I mean, I would have, if I had seen him, I would have wanted to help him. And
Yeah.
people have helped him along, you know, and he's covered up how much he has lost.
Yeah. So that patient probably has Alzheimer's disease, and Alzheimer's patients will fool you until they get more advanced in their condition. Because they look all right on the surface. They have normal social graces oftentimes. They have good eye contact. They're up and about. They're ambulatory. They look pretty good. They can exchange social pleasantries, and everything looks okay until later on. It's obvious to everybody. But yeah, and so if there's somebody who's stepping in and filling in the gaps, and it happens so gradually over time. It's sort of like if you have children, you don't really notice how much they grow, but other people do, right? But the same thing with elderly people as if they have dementia. It sometimes happens so gradually that the family sort of adjusts to it in a gradual way over time that they're not even aware there's a problem until it's really bad for that very reason.
I think another issue was he was well groomed, you
Mhm.
know, his hair and his clothes, and you know, he was well groomed as opposed to someone that's looks like they're in a state of
Yeah, or if he were disheveled, or dirty, unshaven, then you would be more likely to identify a problem. So if he has a really good caregiver, he can also look way better than he actually is, right? So depending on his system around him, he may be able to function quite well for quite a long time in the real world, as long as he's monitored, as long as somebody else's frontal lobe is there to guide him. Okay. Unless there's other questions, we can go on. No? Okay. And we only have a couple of minutes. I wanted to go over one other thing. There's another test that we use here a lot. It's called the CLOCKS, or an executive clock drawing test. And it might be possible that some other speaker will be covering this in more detail. And if that's the case, better. Okay? Because I don't really have a lot of time to go into this. But basically, there's a lot of clock drawing tests, and some of you may have seen them or used them in different settings. The one we use here is a two-part task that invites a person to draw a clock spontaneously, and then there's a second part where they're asked to copy the clock that the examiner draws. Okay, and the unprompted condition correlates very well with the exit, which we were talking about, and is basically can be used to get an approximate measure of a person's executive abilities in relation to their constructional abilities. So the person who does well on the copy version of the task demonstrates that their visual spatial skills are intact, that they can copy a figure, but if they can't do it spontaneously, then that's because they don't have the planning skills in order to carry out this function appropriately. Has somebody talked to you about this already this week, the clocks? Yeah? Okay, that's what I'm assuming that. So I don't want to have a lot of blank looks if you don't know what I'm talking about. I don't want to go into too much detail that you've already heard about it. So you have some sense of what I'm talking about, right? Did they actually demonstrate it? You talked about it? Okay. So anybody have any questions about what you learned the other day then? About the clocks. Okay, so there's clocks 1 and clocks 2? Yeah? Okay. So people can fail clocks 1 and do great on clocks 2 if they just have executive impairment, right? All right, so let me show you some examples. Okay, so this is an example of a sort of well elderly person, 82-year-old, who has a mini mental score of 29 out of 30. Nobody would call him demented based on that, right? And an exit score of 8 out of 50. And on the exit, high scores are bad. So, an 8 is a good score because it's low. And so that, which is a normal score. And if you look at his clocks 1, which is on the left, the unprompted condition looks really pretty good. He has a little bit of an essential tremor, as you can see. He has kind of squiggly lines around there, right? But his performance is well enough to get full credit, as is his copy condition, right? So all scores are normal elderly male. This is a 61-year-old who's, even though 20 years younger than the other case, has a very bad mini mental score of 6 out of 30. So single digits on the mini mental is not good. And you can see on the right box, that's the pentagon item. You know the pentagon item where you're asking them to copy the intersecting pentagons? That's obviously distorted there. This person has a constructional problem. And as you can see in the left box, that's an awful effort at a spontaneous clock, an unprompted clock. And the copy clock isn't much better. Okay, so this is someone who you would not miss, because just your global interaction probably would identify that there's a big problem right away. So the clocks doesn't help you that much with a case like this, because you probably would do the mini mental and it would be bad and you'd say there's a problem. All right. However, in a case like this gives you much better information. This is a patient with a mini mental of 28. Not that different than the first case we talked about. The pentagons look fine on the right. Okay. And but clocks 1 is awful. It's a very impoverished effort. It doesn't have all the elements that are necessary. And although the clocks 2 is very good, so it's not a constructional ability. It's not that he can't draw a clock. He actually can. He proved it. He just can't do it on his own if you don't give him a specific enough instruction. And to sort of go along with this, you see on the bottom, the exit score is 22 in this case. 22 out of 50 is bad. This is the kind of score that you see in nursing homes. So this is an example of how just using the mini mental isn't adequate. You'll assume that everything's hunky-dory, and it's not. Okay. So this is an example where the memory, the language, the constructional abilities, the praxis is all basically good enough for a screen like the mini mental, but there's a big problem in executive areas. Yeah? Okay, here's a 93-year-old who probably most people would consider to have normal aging. Her pentagons are a little bit off, but not too bad, right? The mini mental 29 out of 30. Probably most of you would say if you were 93 and had a mini mental of 29, you'd accept that, right? You'd declare victory. All right, but even in such cases, they have some executive impairment. You see that first clock getting too swift. She didn't draw her own circle. She used the circle that bleeds through the paper. Okay. It looks like she made some sort of tick marks or dots on there to space it, and left out too many elements. So she has some executive impairment. Not a large amount. She's got a 15 on the exit. But even what we would consider normal aging is probably associated with some executive impairment. And when you think about it, there's not that many 93-year-olds who live completely independently, who pay all their bills, make all their doctor's appointments, those sorts of things. They need a little help, All right, so in your handouts, I've given you lists of references where you can get more information. And I'm not going to go over this too much because you have it there in front of you. If you want more information about the exit, using the exit, or the clocks, or using the clocks, you can email Dr. Royal, who's in our department here at the Health Science Center. Royal, R-O-Y-A-L-L, at utesca.edu. And with that, why don't I stop and give you a little chance to ask questions, because we only have about 5 minutes, right?
Yeah, it could take a little time. I actually have a question because we had Bob Hart here yesterday, and he was talking about strokes, obviously.
Yes.
And one of the questions that I had for him was about cognition and what happens when they're trying to dissolve clots. And he actually expressed some concern that I've seen with cardiology and neurology before and cognition is when they try to work together to resolve a problem. Sometimes they fix one thing and make it worse somewhere else. And I'm trying to remember the exact point that he made about the disorder we were talking about with stroke, and that after coronary artery bypass grafts, after CABGs, that he said sometimes cognition gets a whole lot worse. And one of the other things we noticed that there are other extremes, but he said that's in the minority where cognition gets a lot better. And he talked about the notion of the body really sparing the oxygen for the brain first. So he was not real enthusiastic about the issue of improved cognitive function after. But I've actually seen some patients where before they had that coronary artery bypass graft, they would lose hours out of their day. They'd go grocery shopping and they'd sit there waiting to remember who they were and what they were doing there, and they'd sit in a chair knowing it would all come back, and then 3 hours later it all came back and they finished grocery shopping. Meanwhile, their wives are sending out all their family members to look for them. And then they had their bypass surgery and it never happened again. And I was just trying to figure out the physiology of that.
That's real interesting. Yeah, I don't know. It makes you wonder if there's some sort of maybe vascular insufficiency that's relative and not absolute. And I guess Dr. Hart was talking about how his speculation is that the brain gets first pick at the good oxygen, if you will, and therefore improving the pump doesn't necessarily help. But your observation is that perhaps there's hope that it does. Yeah, I'm not really sure. There's not a lot of data about this.
It'd be an interesting study.
And I only see them, or I often only see them after the fact, so it's hard for me to tell. I do see a lot of patients who have never been the same since they had that laparoscopy, back surgery, endarterectomy, carotid endarterectomy, or what have you, open heart surgery, that they're just never the same because they probably had some sort of vascular insult during the procedure. But whether or not I've seen people get better after that, I can't be sure. I've not seen data on that, but that's a good question.
Well, he was real open about the fact that we need more screens placed when these procedures are done so that they catch all of the little emboli that they
Yes.
cause, so that this doesn't happen. And if one would hope, so that, not that it would put you out of business, but
No.
but it would help a lot.
Yeah, that's right. So-
Otherwise, what's the point? You're gonna fix something and then make it worthless because the person can no longer think.
That's right. So the brain needs to be protected at all costs. Yeah. What's the use of having an intact system elsewhere if the brain isn't intact? That's right.
So they need to work together more, I guess.
Yeah. So I'm sure that will be an area that will be investigated more. Yeah, yes.
What population was the exit one on?
It's been studied in a number of different populations. It's been tested in young college students registering for courses at UTSA. It's been used in children in terms of the range of responses. So so let me give you an example. So for people who are sort of young adults in their 20s, the average score is about 4 plus or minus 1. Okay, and if you get to about an 8 or higher, you're in sort of the lowest 5th percentile for young populations. And if you look in different areas, you'll get different scores. So in a nursing home population, you might get a 22, 23, and Alzheimer's population, you get in the 30s. Children, elementary school children, their scores probably don't normalize until they get into middle school.
So it was normed on all age groups?
Well, maybe not all age groups, but those age groups. Okay, yeah. There actually could be more work in that area. Sure.
I have just 2 questions.
Yes.
What she was describing, the other side, I'm assuming she's a teacher.
Yes.
That it just sounds like TIAs when they have that, and I don't know the complete physiology and comparing that other than, getting rid of whatever's causing the TIAs. But
Yeah.
it just hits me because she does that.
Yeah, a lot of people would describe what she's talking about as TIAs. That's right.
Completely coherent. So, but my other question was, if you have people who have some sort of mental or emotional disorder, ADD, and working in the school system, I've seen so many kids, and I keep thinking, what are these kids gonna be like when they're older? And in the beginning of my nursing, where we worked a lot of geriatrics, and we would always, the nurses would always say the comment, or we hear the family say, well, this patient, my mother was really nice, and now she's really, now she's extra nice, or she was real crummy before, now she's worse. So, is there a correlation between any sort of mental illness and it getting worse, the condition worsening? And not the condition of mental illness, but on these tests and the executive.
Okay, I think there's a number of questions buried into your comments. One of those is that children with attention deficit disorder, I think their biggest problem is that they're executively impaired also, that they can't focus on the most relevant behavior of all. So they get distracted by the little bird sitting on the windowsill rather than reading the passage in the book during class. Okay. So there's some question about to what degree that persists throughout life. I think most of those cases probably do normalize, and which is why oftentimes they're taken off medications later on as they develop, as their frontal lobes mature, if you will. Okay. Your other questions have to do more about, I think, what we more broadly consider as temperament. And temperament is probably not entirely a cognitive type process, but how a person reacts to the world around them, how they get along with other people. Some people are calm and easygoing and nothing upsets them and they're polite and pleasant. And other people are kind of irritable and grumpy and hot-tempered and short-fused. And your comment was that those characteristics often tend to get exaggerated as a person ages. And that's really true. but not always. I've had some people, a small number actually, but nevertheless I've seen this happen where a person who's been cantankerous, grumpy, hard to get along with his whole life has a stroke, and now he's a much nicer person. So it's possible, but mostly it just mostly they get more like they've always been. Why don't we stop there? Thank you for your attention.
One pill makes you larger.